Uh, we have lots of time, and I think that we can have about half an hour, as I see, discussion. I would like to ask our speaker to sit down here in front. And okay, okay. Peter, sit down with me. And we are going first to start with the first lecture. That's Cristiano about epidemiology of ankle injury in football, especially here in Qatar. Have you the question? Cristiano.
Please.
First of all, thanks for the nice talk. I have a question regarding the graph where you showed the correlation between the incidence of ankle injuries and the placement of the teams in the league.
Yeah.
I'm quite sure it's written in the article, but I haven't read the article until now. Is it possible that that correlation is due to the fitness of the team, that the fitter teams have less ankle injuries, and at the same time, obviously, the fitter teams we know are usually perform better?
Yeah.
So which would
they teach me to answer. This is a great question, but this is really a great question. This was the first study showing a correlation between incidence. Is this one making? No, it's the correlation showing the incidence of injury, not only ankle, general incidence and team success. But there were studies showing a correlation between the fitness performance and the team success. So we didn't have, so it's possible that this is a bias. We didn't have, unfortunately, fitness data for the same club of Qatar, so we could not say anything about this. But this is possibly true, yeah.
Is there any study comparing the type of shoes used by the sport, specifically the heel raise? Because I noticed that sport shoes for football players are without heel. If we raise the heel or have something that was is there any study comparing the difference between shoe modification to reduce ankle sprain?
I will leave with pleasure the answer to Mr.
I think the answer is no. Specifically to football, I think there isn't. I think when you talk about heel raises, it comes in a little bit to what I was talking about in the talk about how the central nervous system regulates our muscle activity depending on the external environment, the shoes, as well as the internal factors. So if you lift a heel raise, put a heel raise in, then that changes the location of the ground reaction force and the way that acts through the body. And then, again, you'll get a change in muscle activation because of that. Whether that can prevent or cause injury, we don't really know. But I guess in football's such a multi-directional sport that a heel raise probably not going to have a great deal of impact, I don't think.
I'm just aware of one paper that I'm sorry I can't remember the details of at the moment, but I think it was high school basketball got randomly allocated to being given high top shoes versus low cut and found no difference at the end of the year in ankle sprains. But Professor Hurdle might know something more about this. Is there anything you wanted to add? No? Oh, yeah.
I mean, there is something about the cleats with your boots as to, and the type of grass people are playing on, and also the type of fake grass, whether it's just sand, whether it's got the mesh within it. And certainly the cleats seem to make a lot of difference. But it's surprising, really, when we look at it's surprising, really, when we look at the number of, say, fifth metatarsal fractures that are out there, that nothing's been proven. And yet you were saying about the size of the boots. I mean, the South Pacific Islanders who play rugby, they've got massive feet, like, just so wide, and they play on ballet shoes with studs on the bottom, and they've got they've got a very high incidence of fifth metatarsal fractures. I don't know whether we haven't been able to prove the same in fifth metatarsal fractures for soccer. It must make a difference, I think.
Given what Rod presented in terms of the lateral projection of the center of pressure in people with chronic ankle instability, is that something that you look at as potentially something that you could use orthotics to try to correct? And if so, how might you do that in terms of which side would you try to control motion on?
Discussing feed-forward mechanisms in control of movement later on, and I guess in terms of an orthotic intervention for that, and we showed in the study I presented, we actually looked at the duration of burst activity in a number of muscles, and one of those was peroneus longus, and we showed that an anti-pronation orthotic actually increases the amount of activity in peroneus longus. But that is counterproductive to what you're talking about with an already laterally deviated center of pressure. So if we're trying to manage that in an orthotic, we're probably looking at lateral posting through the clinical or through the lateral forefoot, which then will reduce the demand on peroneus longus and peroneus brevis to control that inversion. I guess what that will do is after initial heel contact, and that should direct the center of pressure more medially and provide obviously a mechanical change.
Other questions?
Yes, I have two questions. Recurrency of injury, because you say that the incidence of injury is less frequent than like the word incidence of accident in the ankle joint, and recurrency is more than the like usual. So what is the cause of recurrency of injury? Whether there is some sort related to the injury occurred before or the I notice also that other injury occur, not the ankle, when they have injury in the ankle as well, like knee injury or foot injury. The second question for Rod, actually, you mentioned about the dorsiflexion injury with injury in the ankle. And I noticed a lot of injuries with the plantar flexion as well, and combined with the cubometatarsal joint injury. Whether have you came across to these injuries as well? No, thank you.
We noticed that when we talk about ankle injuries, we mainly talk in 90% of the case of ankle sprain. So also when we talk about brain injury, we are talking about ankle sprain. And so I think that we have to talk practically of two issues. Also one, actually, the ankle instability. And I can tell you that in our study, all the injury were recurrent ankle sprain. There was no other kind of issue. So I think we have, if you ask me the cause of that, the reason of that, I think that all the risk factors predisposing for a recurrent ankle sprain, mainly the instability coming from the first injury. I mean, I don't know if this answers to your question. All our recurrence were recurrent ankle sprain. So this is due to instability, and the instability is due to I don't know, wrong treatment. I mean, surgical versus conservative, early return to play, and all these things.
My question, what is like recurrency happen? Why the recurrency happen in the ankle? Because of the previous injury, or there is something else rather than they have recurrency of ankle injury?
Yeah, I think that my personal opinion is that No, but it's not working. I think that if we talk about instability, the main reason is the previous injury of the ankle itself. But I will leave it.
Professor Hurdle's going to talk about ongoing gait deficits after ankle instability as predictors of recurrence. And we touched on it for 30 seconds here, but the people it seems who sprain once and never sprain again are very different from the people who go on and keep spraining. And the big difference seems to be during their gait patterns. The other thing, your second question you mentioned about you see a lot of injuries in plantar flexion, and I think need to be a little bit careful here. Every time you do see an ankle injury and you have some video footage of it, go back and have a look at it, because in normal gait, if I'm running, my foot lands underneath me. So by definition, I'm in dorsiflexion. So for my entire stance, I start in neutral and I go into further dorsiflexion, and I'm in plantar flexion during the swing phase. It's pretty hard to sprain your ankle during swing, although what you do in swing probably determines what you're going to do in stance. You can land in plantar flexion when you're running down a hill, or when I land on something and there's something underneath my heel. But typically you're going to land on something underneath your forefoot, and if you try it out for yourself, as long as your knee is close to over your ankle, if something's under my forefoot, it's going to push me into dorsiflexion. So the injury most likely in the sagittal plane, it's dorsiflexion, but it's an inversion and internal rotation injury. So I think we tell our patients, yeah, did the injury happen like this and in? And they go, yeah, that's what happened. My foot turned in, but they don't know whether it was up or down. And when you actually go back and have a look at this, by and large, this happened in dorsiflexion.
Christian, you talked about, because of the high recurrence rate, looking at the return to play rule. Are we currently implementing, say, some of the stuff that Rod's just discussed as far as return to play, or is that something that we'll look at in the future when you look at return to play?
Yeah, after.
So I think that epidemiological data are the basis for all the intervention, and I think that together with the data on hamstring, we are starting an intervention. On groin, we are starting an intervention, and knee, ankle. I showed that the day loss is not very high. Probably the recurrence, the high level of recurrence is the real problem in this case. And so the intervention has to be there. Yes, I'm not doing personally, but we should look at this. Sometimes, now I spoke as a team doctor, sometimes it's not easy. Sometimes it's not easy to satisfy all the parameters before coming back to play, and my colleagues in the audience knows. And sometimes in the club it's not it's the same as in a hospital. So I perfectly understand my colleagues which have this data. But I think that someone should do something about that. I don't know if in physiotherapy department you are working on this.
I think it's time for morning tea.
Okay. I have one observation about the shape of the foot. The heel varus shape of the foot maybe is a contributing factor in ankle sprain injury and in recurrence of ankle sprain injury. Have you noticed that people with heel varus have more tendency to sprain their ankle and more tendency to have recurrence of sprain?
I have to say I haven't noticed much of an association between static foot posture and what people do dynamically. An example I'll give here, which is related, is I used to make a lot of mistakes with people with peroneal tendinopathy who had presented statically with pes planus. And so I would see this marked pes planus and I would think, well, obviously what I've got to do is try and get the podiatrist to get their foot and give them back an arch, and then we'll go and start to sort out the rest of their foot function.
and invariably these people got lots and lots worse. And then some work Craig Payne, a guy from Victoria in Australia, was doing was looking at the resistance to supination. So he actually puts a dynamometer on the medial arch of the foot. These people stand down, and he sees how much force it takes to resupinate these people. And what it probably turned out I was doing was incorrectly. These people who might stand dynamically with a pes planus, but they very easily resupinate. So it's a very low load to resupinate. These people very quickly go over onto their edge. So as soon as I start to ask the podiatrist to wedge them medially and correct their static foot posture, I'm sending them over laterally, and their perineal tendinopathy gets markedly worse as I abruptly start to overload them. So that my little snippet is that I think we can't look at all at static postures and infer anything about what's going on dynamically, because every time I've done that, I've got it 180 degrees wrong. Luke might have something to add.
I think Rod's covered that. I do think that if you have a big varus angle at the knee, that certainly has an impact on contact and where you contact. So I guess you're going to be contacting more laterally if you have a big varus tibia or a varus knee. But it's what happens after that point that where we get the problem, as Rod's discussed.
James, can you comment on your post-traumatic cryotherapy protocol after an ankle injury? Because many players ask you, how long do I need to put ice, how many times, how many days? What is your protocol?
Post injury, they go straight. So if they've had an ankle sprain, unless they sit in the coach on the way back to the club, they've got it on all the time. Post-operatively, I use it certainly for 2 weeks, and they get it every 2 hours, and they'll set the clocks by it, and they'll run it during the night as well. So I'll leave it on as much as possible, because I think it just helps with physiotherapy later on. If you can squash, it's not just the icing, but it's also getting the compression on it, so you can get them moving earlier, and any swelling there, it's just going to play havoc with the physios. And the interesting thing I was saying about looking at the distraction mechanism, or the distraction, getting the dorsiflexion back, I think that's incredibly important, because the posterior capsule just thickens and gets tight. So when you try and get the dorsiflexion, what you're actually doing is you're hinging, and that's what I think causes the anterior impingement people get when they're trying to get their dorsiflexion back. It's not because they're actually getting true dorsal impingement, it's just that the talus isn't rotating around because the posterior capsule is so tough. So actually, if you can stretch it up, then you get the rotation in there rather than just getting the hinge at the front. I don't know what you think. But
yeah, I'm really not sure why it works. It's just one of those techniques that I found I generally couldn't get any change when I used my hands. The forces weren't big enough, and I've post-hoc tried to rationalise why it works, but we see an immediate change in the dorsiflexion range of motion that persists out to days. But if you do it frequently, and then you can get that range of motion back, and then they can use that functionally in your exercises, in the rehabilitation, whatever, then they can maintain it over a longer term. It's interesting to know how to do it. Would you ever consider, some of these guys, thinking about a patient that we have at the moment who's just got no dorsiflexion, on that knee-to-wall test, with his toe touching the wall, his knee can't get to the wall, and we have genuinely bashed this guy as hard as we can. Is there ever an indication to go in and perhaps release that posterior capsule, have a look around?
it's interesting. I've had a wholehearted poor success in doing it from the front, because the anterior impingement, and that's why I think that to try and get better dorsiflexion, unless they've got a big osteophyte there, that anterior impingement, that stiffness is due to something else. And more recently, I've been in through the back. I've only got anecdotal evidence, and I've only got 3 professional soccer players that I'm pretty brave enough to do it on, because it is experimental, but they couldn't play because they hadn't got dorsiflexion. One of them was very high level, very well known, and they got more dorsiflexion. They didn't get it completely back, but they got enough back to be able to return to play, and got enough back so the physios could work with them and get them back there. So I think it's supposed to be capsules that, as Seattle would say, that gastronitis is the root of all evil. The posterior capsule and ankle injury is the root of all evil.
I'm sorry, I have a question. James, actually, I'm interested in knowing the arthroscopy you mentioned. I mean, will you do it to non-sport people, and when will you do that?
I can't
do it to all non-sportive people, because the number of ankle fractures we get through a casualty department and emergency department is too big. I think the elite players, yes, I do it on routinely now to diagnose it. And perhaps we should choose the ones in the non-elite group, the recreational players, the supination, external rotation, for injuries and things like this, with VR falls. Then we perhaps ought to be doing that. I'm not doing that yet. I'm just purely reserving it for the elite group, which is what we're talking about today.
One question from James Calder. Probably it was on one of your videos, but you're testing during a diagnostic arthroscopy the degree of instability when there's an isolated syndesmotic injury. And what's your indication to operate or to leave it?
It's controversial. And wherever I seem to go in the world, I ask everybody else, and all the other guys, and say, what do you reckon? And they'll go, well, we do it this way. I say, what's the evidence for that? They go, there isn't really any. It just seems to work. My indications are, if you've got an MRI scan shows they've got the AITFL has gone, they've got interosseous ligaments gone, there's some bruising around there, or some high signal within the PITFL, maybe got a bit of touch bruising across the tibia where the PITFL attaches sometimes. You've got a high index of suspicion that they've got a syndesmotic, potentially unstable syndesmosis, which isn't static. It's static, it's fine, but when you rotate it, it's abnormal. The clinical tests, I get them back preferably at about a week and re-examine, because they're sore everywhere at the first few days. So I get them back at a week and retest it. The squeeze test, the external rotation test is the most sensitive, but it's fairly non-specific in that they'll be pretty sore even if they've just got a slight twist of the ATFL as well. The squeeze test is less sensitive, but if you get a positive squeeze test, it's more predictive of a poorer outcome in the long run. It certainly has a longer return to play. We know that, so I use that one. And I also use one that is in the physiotherapist journals, which, being arrogant orthopedic surgeons, we never read the physiotherapy journal, so I didn't know about it until Harlequin's physio came along and showed me it about 4 years ago. And it's the when you're doing a knee to wall test and there's syndesmosis stabilisation afterwards. So you do a knee to wall test and they get this pain, high ankle pain. You then tape it up and you stabilise the syndesmosis, and you can get it takes the pain away at the same distance away from the wall. And that appears to be, we've just recently done a study looking at it. It's not published, so it's just anecdotal at the moment, but that seems to be very predictive. And the other one is doing a standing external rotation test. So if those are positive, then I'll do an ankle arthroscopy. I'll do an EUA, but if I can't get it to open up, but I'm convinced there's something wrong with it, then I'll do an ankle arthroscopy to assess it. And if it opens up at arthroscopy, which is probably the best way I've found to look at it, I will fix it. And then you can decide whether you want to use a screw or a tight rope. I personally use a tight rope, because I think it has certain advantages. If you've got a very big forward rugby player, I tend to use screws because I don't believe that the tight rope's strong enough yet, but I tend to use tight ropes.
And you look at arthroscopy if it's completely ruptured or the degree of
But there's a couple of reasons for doing the arthroscopy. One is because the AITFL often swings down from its fibula or its tibial attachment and swings down, just sits there, which is probably a cause for later anterolateral impingement. It just sits there and gets jammed in the joint. So I'll remove that if it's just swinging down. And then I will assess the degree of opening of that. And sometimes if you've got a 5.5 shaver, you can literally just put it in where the AITFL was and you can just drive it right the way through. Well, you're not supposed to be able to have 5.5 millimeters difference there. So that, by definition, in my view, has got to be unstable. It's controversial. I've got no evidence to support it, but in the 6 years I've been doing that for the professionals, we changed it a lot before then. We were waiting for them, and we found there was a high incidence of recurrence. We looked at it mainly from the rugby and 6 Premiership soccer teams. And we looked at the recurrence rate and the length of time people were having out. We thought, this is crazy with these syndesmotic injuries, and it's come down. It's not published yet. Maybe John will have a look at it at some stage, but it'll come out.
There's another thing that
regarding the gliding that you put in the ankle was very interesting, just to pull the tibia backward and pull the talus forward, just to mobilize the anterior capsule of the or the anterior wedge of the ankle. So did you try just to go in reverse to pull the talus forward and tibia backward with the manual, or that, whether it is working together like same, or this is different when you are pulling the tibia backward or forward? The second question regarding the arthroscopy. Did you try to use ultrasound to see the grade of injury before start to go for like intervention by doing arthroscopy? Thank you.
Mine's pretty quick because when you try and do it the other way, so lay them over prone and put the belt around, it hurts the Achilles tendon too much. Now, I rationalised it in my mind that I was doing something about the anterior structures, but from what Dr. Coulter's saying here, obviously the entire ankle's being distracted, so potentially it's the posterior capsule that's getting lengthened. I genuinely don't know what's being lengthened, but I know after I do it, I get more dorsiflexion. So I'm trying to think why it works, and it seems to work better when you can put the belt on anteriorly and distract it even further. And clearly when I do that, I'm distracting not only the anterior, but the posterior parts and the medial and the lateral parts as well. I'm basically dislocating the ankle. So to ultrasound?
Sorry, that's me, ultrasound.
Yes, for investigation, the degree of ligamentous injury and the ankle injuries in general, whether you try just to use like ultrasound as diagnostic tool before starting to do arthroscopy.
Yeah, certainly for the syndesmotic injuries, we've been using that a lot more. Professor Mann from Israel published a study looking at the sensitivity of and specificity of ultrasound versus MRI scan. It's not done a lot in the States. They don't seem to like, whenever I go to the States, they don't seem to do as much ultrasound there, but we use a lot of it in the UK. And I find it's great because the radiologists can actually tell me. They can also identify which part of the deltoid, which is often quite difficult to look at. They've looked at that, looking at some of the deltoid for me, to find out which part of it's ruptured and whether it's complete or otherwise. So yeah, I find ultrasound great. I can't do it. I don't. It looks like a weather map when it comes through, but so I have to be there when the radiologist, and I'll just nod in agreement when he shows me what it is. Yeah.
Can I just complete? I didn't present this data, but there were data regarding diagnostics process, all these ankle injuries that I presented, and 46% of them requested an X-ray. The doctor requested an X-ray for them, and 22% of them underwent to an MRI, and only 3% of them underwent to an ultrasound. So I think that my two conclusions were that first of all, probably the number of X-ray is too high in accordance with the normal numbers in the literature. So the diagnostic process has to be reviewed as well. And then I know that because I was here, it's a technical problem. Not always we had radiologists available in the past years, but I think that from now onward, ultrasound, based on the literature that is showing this value comparable to MRI for ligament injury, has to increase in Qatar, reducing the number of MRI from many reasons.
Last question. One more surgical question for James. A little bit overlapping with the previous question now, but could you clarify and could you give us more detail about your strategy and how you managed the malleolus fracture? Because you mentioned at the end of your presentation that there is a pressure to quick ORIF after this kind of surgery, this kind of trauma, and we know that the edema can be during a few days, and sometimes it's more than 3 days. So do you recommend in practice, do you prefer to do as soon as possible? Do you prefer to wait to do an MRI, and you mentioned that it's not always so accurate? Do you think that with the arthroscopy you can do that very quickly to do ligamentous assessment? How is your strategy in this way?
I would prefer to have all the information there. So I would prefer to wait 72 hours, get an MRI scan, ideally 48, 72 hours. That's what the ideal situation is. Then as far as fixation of if you've got isolated medial malleolar fractures as well, I haven't come on to that, but yes, in soccer players, they get fixed. There is a non-union rate. You can give them to the physiotherapist, they rehab brilliantly when you get them going, you can get them going quickly. Whereas otherwise, if you don't treat them operatively, you've got to stick them in a cast for 6 weeks, non-weight bear them, because there is a non-union. So I think it's crazy in an elite athlete not to fix them, absolutely crazy. Although there is evidence they heal up, but that's not in an elite athletic group. We're speaking about different people. So, Jan.
May I add one question to this? I have lately seen at least a couple of football players with a stress fracture of the medial malleolus, like a crack line that's going directly upwards. Have you seen that?
Yeah, we've got a large series of them now, and that is associated with the varus ankle. Those definitely need to be fixed as well. They're often associated with a slight bony spur across the front of the ankle. Chris Cosia from Indianapolis described arthroscopic removal of the spur at the same time as fixation of the fracture. I think that's probably right. I tend to I tend to do a mini open incision over the fracture and actually scrape up, because it's sclerotic, it's like chalk in there, and take out that fracture line, that bone, and I put some graft in there. We can talk about whether we use PRP or parastim and all the rest of the things. That's going to open the whole hornet's nest. But then I fix them, because they will go on to fracture. We've got one Rangers player, I think the other one wrong. Rangers player who had one on one side, which was a complete fracture. He had this medial ankle pain, and then he went to vertical fracture right the way through. We fixed that, and then the following year, once again, he hadn't been to result. He hated having orthosis in his things, because he'd got really quite various ankles. We'll come on to that. But he then got one pain the following year, and after 1 month of pain, he went, "Doc, I'm going to break my ankle." And I went, "Yeah," so we fixed it.
What's your post-op protocol? Immobilization, if you have a screw fixation, or
no, I'll get them moving.
Right away.
Yeah, as long as they've taken the if they've got a big anterior spur, anteromedial spur, remove the anterior spur so there's no impingement, there's no blocking going on there. I get them over to the physiotherapist and I get them moving it again. They've often got a bit of gastroc tightness as well. Get them an orthotic review. I will leave them probably every day, just only for 2 or 3 weeks, non or partial weight bearing. But actually, I won't immobilise them. I want them going pretty quickly, because there's no reason to. Unless it's a displaced fracture, but a stress fracture, no, I get them going immediately. And then put them on the Alter G and progress them from there. But they're often back. It's a protected stress fracture now, so they're often back on the Alter G in about 4 weeks building up.
I'm sorry, it's 11:05. We have to stop. Thank you very much, you four. That was excellent. Thank you, everybody. And we are going to restart at 11.